Supposing you start with your standard cocktail in a patient who's bacteremic, septic, hypoxic, hypotensive, high lactates, and you've guessed wrong, right? And you're giving these antibiotics and you've done your best. How quickly do these patients turn to stool?
You know, if you have an antibiotic that can save your patient's life and in your right pocket and you use the antibiotic from the left pocket, you know, you may lose the patient, and you may lose the patient very quickly, and it all depends on how sick the patient is and how dynamic the patient is. But as we know, you know, within a day or two or three, the patient may die if not treated adequately. On the other hand, you know, there are patients who are stable and in which you don't have to take such an aggressive approach. But deterioration from infection, you know, has not changed, and some of those and particularly Pseudomonas and some of those very virulent bacteria can kill people very, very quickly.
I think, you know, we're talking about drug-resistant pathogens, but we still all see people dead within 48 hours of pneumococcus.
We do.
We still see people dead within 48 hours of MSSA endocarditis, right? So, you know, we're talking about gram-negatives, but rapidly deteriorating patients with infection exist for all of us, and it's not only for ugly gram-negatives. I think the other thing we're missing in this conversation is source control. And, you know, we're talking about only one piece of the toolkit for taking care of these patients. And no matter how much antibiotic you throw for someone, if you think they've got pus in the belly,
go for the belly.
Right, you've got to, you know, you got to put a needle in, and you got to get your surgical colleagues involved. You've got to, you know, source control is crucial. If you've got a catheter that's infected, and you're leaving it in, and you think you're going to treat through, you know, a biofilm that we've talked about, forget it. You know, and that's true particularly for Candida and for gram-positives and even for gram-negatives. And so people fail not only because we gave the wrong antibiotics. There's host failure, but there's also source control failure.
Right. But just to be practical, you know, because we came with a lot of doubt, and I think we expressed a lot of opinions saying why
they brought us here because we all have lots of opinions.
No, we want you to agree.
Why are and everything was true. And why are things complicated? And why is it difficult? And why can't you get it right every time, even if you use rapid diagnostics, even with the coming rapid diagnostics into the future? But I think that it is important to know that at the end of the day, you need to treat a patient, and you need a practical kind of paradigm. And I think that it is important to know that one can put together a practical paradigm that will help clinicians treat.
So help me do that. What does a hospital do?
If you ask me, and that's my subjective
Okay, let me ask you, how do you do that?
All right. So this is how I would do that.
So first tell us how he does that.
Well, I mean, that's my practical paradigm. I mean, I start with the patient and I ask myself how sick the patient is, or in other words, what will happen if the patient is not getting treated adequately? And you would be surprised, in most patients, the answer is not much is going to happen in the next day or two. And that gives you a lot of time, and you don't need to be very aggressive, and you can preserve antibiotics, and this is the bulk of our practice. But this is the most important question. Then the second question I would ask, what do I think is the source of the infection? As Maren said, sometimes you have no clue. Sometimes you know exactly. The patient had an observed aspiration episode. You talk about the ICU. The patient had those recurrent urinary tract infections, and his urine is becoming clouded. You know, sometimes you have very good sense. And you ask yourself, what kind of bacteria cause these type of infections? What do I have to cover? And this will give you a clue. Then you ask yourself, what did a patient show in the past in terms of infection and colonization? This is always helpful. You want to cover that, even though you know that it's not necessarily going to be the previous bug that's going to and then you ask the three classic risk factors for resistance. What was the exposure of the patient to the antibiotic? Exposure to healthcare. So we talk about Pseudomonas. Pseudomonas is unlikely in the first day or two or three of hospitalization for someone who hasn't seen healthcare. So someone came for surgery, and the surgery got complicated, and he came from the street. He's less likely to have Pseudomonas in the first day or two, far more likely to have it on day 7. So exposure to healthcare, exposure to antibiotics, and patient health factors, as you mentioned, being immunocompromised and so forth.
Okay, but you know, it's funny because you mentioned something that I think is important, which is I had a resident the other day saying, this patient is septic, but he's a happy septic patient. And I said, how do you define happy sepsis? He's sitting up in bed, he's smiling, he's not intubated, and yet his blood cultures are positive, and you know, look, his lactate's going up, but he's not septic, near dead, sick. So they come in different flavors. So I guess that's what you're implying too.
But the other point is, I think that's crucial, is you're never going to show a mortality risk for inappropriate antibiotic therapy in low risk for death patients. So when you look at the literature that all of us have contributed to, there may not be a mortality penalty in some of the patients that Yoav's describing. There is clearly a morbidity penalty for getting it wrong. And that morbidity penalty is measured in subsequent escalation of care and in length of stay in the hospital. And so I think it gets to a principle that we've kind of danced around, especially as it relates to any of the newer antimicrobials, which is cost, and that is the most expensive antibiotic is the one that's used inappropriately or in a delayed fashion. And so the point is, yes, you look at this patient, you think you have time to get it right. Yeah, you have time to get it right if your endpoint is mortality. If you think about it from the perspective of, well, I'd like to get this patient out of the hospital as quickly as possible and with as few complications as possible, the clock is always ticking. And it's not like you can sit there and, intellectualize about the process. You still have to make a decision, which is why at my residence, I pull their badge and I say, it says MD after your name, make a decision.
So here you have the clash between the intensivist and the infectious disease doctor, and we both
I'm
have
liking what I'm hearing over there.
And we both have the same interests, of course, but I guess what Annie is saying is that it's always important.
I thought I said it already.
It's always
No,
important.
you did,
It's always
trust me.
important to get it right early, but I guess what you don't say is that I'll always use my first-line antibiotics.
No, I'm not saying that at all. I'm not saying I have a hammer and everything's a nail and I treat them all the same.
Right.
But I'm saying you can't fall into the trap of thinking, oh, there's no consequence for taking my time on this decision.
Because the cheap, common antibiotic, if it gives you an extra week in the hospital, is very expensive.
Correct.
That's what you're saying.
Correct.
Well, but you also have to realize that some of the antibiotics that we consider to be old and cheap and
They
not
work
very
pretty
active
well.
against are the best antibiotics that we have. Of course, the best examples are from the gram-positive arena where we use a lot of vancomycin as a super antibiotic, but all those cheap, not very cheap sometimes, but cefazolin and so forth are much better than vancomycin. So there is some to gain, there is some to lose, but I think the patient should guide you, and I think that's the principle.